Thank you very much for the kind invitation. I switched to English, although I understand Turkish, but it would be very tough for me to give the talk in Turkish because the medical Turkish is a little bit a problem for me. So thank you for the very kind invitation to join your highly appreciated meeting here in Antalya. And it's my topic to discuss with you pancreatic cystic lesions from a gastroenterologist point of view. And over the last decades, we had a huge debate between gastroenterologists and surgeons. But in Munich, when I was working with Mert and Güralp over there, we settled that discussion because we agreed how to manage these patients. And meanwhile, as we monitor the literature, we have seen and come to the conclusion that there is not a big debate anymore about the management of cystic lesions. We came to an agreement. And I hope Mert, when he is giving his point of view, is sharing this position. Now, what is a gastroenterologist's point of view? First of all, as a basic scientist, we knew from the early decade in this century that mucinous lesions are precursor lesions of pancreatic cancer. This is a sketch showing that mucinous lesions have a risk to develop pancreatic cancer. And that was the reason why initially there was a big debate on mucinous cystic lesions in the pancreas, how to manage them. However, if you look at this graph, you can see that the number of diagnoses of cystic lesion has increased over the last years. However, pancreatic cancer has not increased in this size. So there is a discrepancy between this graph and this graph. And this discrepancy has to be discussed. And this discrepancy asks for a solution and selection of the right patients that should undergo resection because they may have a risk to develop pancreatic cancer. Now, the problem of cystic lesion in the pancreas is settled through some fundamental facts. This is the first fact. We do see many patients in our outpatient clinic with cystic lesions. At the same time, the size of the cystic lesion is decreasing. This is probably due to the better information of the patients on this kind of cystic lesion, but also due to the improving imaging technologies. The other fact is shown here. Most of the patients are asymptomatic. So we have more lesions, more patients, smaller lesions, and in most of the cases, the patients are asymptomatic. And this is further aggravated through the fact that most of the patients that we see in our outpatient clinic are elderly patients. So more patients, more cystic lesions, smaller lesions, asymptomatic and elderly patients. How do you want to manage the cystic lesions in such a population? Now, my colleague, the radiologist, has shown many slides that I will skip over because they are redundant. This is one of the slides. I will focus on these 4 cystic lesions because pseudocysts are not classical mucinous cystic lesions. And these 4 lesions will make out of the cystic lesions like more than 90%. So these are the 4 entities that we should focus on when we discuss about cystic lesions in the pancreas. Solid pseudopapillary neoplasia is a very rare entity. It affects less than 5% or it accounts less than 5% of the pancreatic cysts. And in most of the cases, the patients are young and the SPN is localized in the tail. And because of the age of the patient and even the risk is not very high, in most of the cases, we recommend doing surgery. There is no disagreement with the surgeons. If this SPN is big, let's say 5 centimeters, localized at the tail, we'll talk to our surgeons, left resection, maybe robotic assisted, is a good option to offer these patients. So there is no big discussion about the management of SPN in this scenario. The second lesion that is very frequent and also mentioned before are the so-called serous cystic neoplasia, SCN, which is about 10 to 20% of the cases of cystic lesions. They are in most of the cases benign. If you are sure with the diagnosis, you can be safe recommending the patient just to follow up these serous lesions. You don't need to send them to the surgeon, because a large cohort of more than 2,600 patients with SCN have been documented, and out of these 2,600, about 3 cases were documented as being cancer. So less than 0.1% of the cases were transformed in cancer. And those patients that developed cancer out of SCNs were symptomatic with abdominal pain or jaundice, and the size of the cysts was big. So SCN has a very low potential to develop pancreatic cancer. If they do so, which is very rare, patients have big cysts and are symptomatic, not asymptomatic. How can you be sure that the lesion you are seeing on the CT scan, on the MRI scan, is a cystic lesion? The radiologist has shown some characteristics which might guide you towards a diagnosis. But as a gastroenterologist, I will, of course, advocate diagnosis, EUS guided, and this is a puncture. You can perform EUS FNA if you want to discriminate between a serous lesion, which is in most of the cases benign, and a mucinous lesion, which has the potential to develop pancreatic cancer. You can do that by EUS-guided puncture of these cysts. If you do so, you can aspirate the liquid in the cyst and send it to the clinical chemistry for diagnosis of CEA, which is a very good marker to discriminate between mucinous and serous lesions. For all those who did EUS FNA, know that it is also easy, without asking clinical chemistry, to differentiate between serous or mucinous lesion. You can just take the liquid between your fingers, and if you get like spins or like it's sticky, then you can be sure it's mucinous lesion. So EUS-guided FNA is the right approach from gastroenterologist's point of view to discriminate between serous and mucinous lesion. There is also no big debate on the management of such a lesion, which is called the MCN. This is a mucinous cystic neoplasia, in most of the cases affecting female patients, and they are most of the cases in the age around 40 to 50, and it's localized in the pancreatic tail. In most of the cases, you don't see a communication between the cystic lesion and the pancreatic main duct. And the histology is alerting you towards potentially epithelium which comes from the ovary. So this is a so-called hypercellular spindle cell component of ovarial stroma. So if you see this lesion, it is, from our point of view, and I think the surgeons will agree with that, something that we need to consider for surgery. Because the patients that we see with MCN have a high risk to develop cancer up to 50%. And given the fact that these are female, young female, and again, the resection is not a big intervention because it's mostly localized in the pancreatic tail, you would recommend these patients, particularly if the size is over 4 or 5 centimeters, you would recommend resection, laparoscopic left pancreatic resection. But even in the case if an MCN transforms in cancer, the prognosis of this subtype is still better than pancreatic cancer, with a survival, 5-year survival of close to 60%, which is definitely not the case in pancreatic cancer right now. The discussion on the management of MCN, SCN is settled. There is no big discussion anymore. The only thing that we need to discuss with the surgeons further, but we have reached some agreement, is the management of the so-called IPMNs, main duct IPMNs and branch duct IPMNs. The first consensus conference tried to form a recommendation towards how to manage the cystic lesion IPMN. That was in Sendai 2006. By that time, we agreed that the main pancreatic duct is defined by the dilated pancreatic duct over 10 millimeters, and the so-called branch duct IPMN is defined by dilation or cystic dilation of a branch duct with communication to the main duct. Still, the main pancreatic duct is less than 6 millimeters. So Sendai 2006 helped us to define main duct versus branch duct IPMN. When it comes to main duct, I think we reached relatively quick an agreement on how to manage main duct IPMN. We knew that main duct IPMN has a high risk to develop invasive pancreatic carcinoma, shown here on the list, up to 60–70%. So there is no big discussion that we need to survey and probably resect the patient with main pancreatic duct IPMN. So with Fukuoka 2017, which is the updated classification of cystic lesion, we usually recommend resection generally, but that means we have to see the patient with its comorbidities and whether or not he is able to survive surgery. So, but resection generally is the option for the treatment and for the treatment of main duct IPMN. In 2017, we also defined so-called high-risk criteria, which means dilated main pancreatic duct over 10 millimeters, mural nodules, and jaundice. So the presence of these high-risk criteria asks for surgery. Worrisome criterion means the main pancreatic duct is not that much dilated. It's dilated between 5 to 9 millimeters. So in some of these cases, we usually do pancreaticoscopy. If a patient presents with such a dilated main duct, we perform pancreaticoscopy to define whether or where is the papillary neoplasia, because in some cases, particularly in elderly cases, you do not want to do total pancreatectomy. Maybe you can do a limited resection like tail resection or Whipple. But this is not recommended in the Fukuoka criteria. The situation with the BD-IPMN is a little bit more difficult because we do have many studies that show that the risk to develop pancreatic cancer out of BD-IPMN is very variable, with 12%, 3.6% until 30%. So that's not as clear as for main duct IPMN. But for the branch duct IPMN, based on mostly retrospective studies, we have agreed on the so-called Fukuoka 2017 criteria, defining in branch duct IPMN so-called high-risk criteria, which means obstruction and jaundice, or mural nodule bigger than 5 millimeter and contrast enhancing, and a main pancreatic duct that increases over 10 millimeter, and also worrisome criteria like pancreatitis, cyst size, or thickening enhancing cyst walls. So we do have right now criteria that allows us either to send the patient to the surgery or to argue for surveillance. And this is the scheme that came out of the consensus conference in 2017, showing that the algorithm is based on the presence of main or on worrisome and high-risk criteria. So it is now possible to go along these criteria to define surgery or surveillance in these patients. I don't want to go through this algorithm. I would like just to stress something that is important from gastroenterologist's point of view, because from studies we know that mural nodules are indicators for the presence of cancer in these cystic lesions. And how can we find mural nodules reliably? Radiology is one option, but there is a small study, but important study, that compared MRI, MRCP to EUS, and particularly when it came to mural nodules and solid components within the nodules, EUS seems to be superior to MRI. And this has been confirmed in another study, which showed that EUS is in fact very reliable in defining high-risk criteria, enhanced mural nodules in cystic lesion in the pancreas. And this was also confirmed in this study that showed that in the surveillance of patients with cystic lesions, EUS is the right tool to reliably detect cancer in the pancreas and high-risk criteria in the cystic lesion. So when it comes to main pancreatic duct, we have many studies that argue that 10 millimeters is the right way to go to decide for surgery or not surgery. And this is a list showing those studies. I would like to pick out one study that retrospectively analyzed 320 patients with cystic lesions, and they showed that main duct dilation over 5 millimeters was a good criterion to define cancer in this lesion, something that we would not expect from the Fukuoka criteria. And you can see that even cystic lesions with main duct dilation had like cancer in 60%. This is a good published study, but with some weaknesses when it came to the management of this study, particularly because they only relied on MRI, not on EUS. So this is something that a gastroenterologist would never accept, because the argument that it's observer dependent, that applies to MRI as well, because the MRI devices are not the same everywhere. So as a gastroenterologist, I totally advocate the use of EUS, because this is the right tool to identify risk factors within the cystic lesions much better, not much better, but better than MRI. This has to come together, but it's not the right way to exclude EUS from the surveillance of cystic lesions. So the AGA guidelines, they said, okay, if a patient after 5 years has no increase in size of the cystic lesion, you should not monitor them anymore. That is not right, because we know from a recent study that even after 5 years, a cystic lesion that was not really growing for 5 years can develop pancreatic cancer. And this is highlighted with the red spots here, arguing that surveillance of patients, if you want to survey patients with cystic lesions, you should not stop it after 5 years. You should follow up these patients more intensely, because they are at a high risk to develop pancreatic cancer even after 5 years, and that was the case in about 6%. So let me conclude. As a gastroenterologist, I would say SCA can be monitored and should not go surgery unless they develop symptoms. And patients with MCN should undergo surgery, but at least should be discussed with the surgeons, because I would not resect a patient with MCN like 2 centimeters. You can monitor them. Main duct IPMN more than 10 millimeters is an argument to go for resection. The management of BD IPMN is more sophisticated, but you should use EUS together with MRI, because with EUS you can see the contrast enhanced mural nodules, which are indicators for the presence of high-grade dysplasia. And you should use the Fukuoka criteria, because many other studies have also shown that these are good criteria. And you can monitor BD IPMN with worrisome features. With high-risk criteria, you should talk to the surgeon for resection, and the monitoring intervals still remain unclear. But in any case, you should always see the whole patient with his age and comorbidities in the decision process, how to manage and to undergo resection of BD or MD IPM. And with this, I would like to thank you for the attention, and I'm happy to take questions if there is some time left. You know?